Hi, I'm Hannah Gallmer, and I'm an occupational therapy doctoral candidate at the MGH IHP. Today I'll be presenting my ADE topic, which is titled Implementing the Visual Immersion System in Occupational Therapy Practice. My faculty mentor is Dr. Tara Mansour, and my site mentor was Kara Morrison Smith. A little bit of context for my project is that I collaborated with Autism Care Partners, which is a private outpatient pediatric day program located throughout the New England area, where all speech language pathologists have been trained and are actively using the Visual Immersion System, or the VIS, which is an evidence based visual and language acquisition framework designed to support mainly individuals with moderate to severe autism spectrum disorder, or ASD. However, occupational therapy practitioners are not yet using it in their practice within the network. I partnered with their clinic in Danvers, Massachusetts to explore the integration of the visual immersion system into occupational therapy practice for children with autism spectrum disorder. My project focused on developing strategies to help occupational therapy practitioners incorporate VIS video modeling into their sessions, grounded in firsthand experience designing and delivering VIS aligned intervention videos. Occupational therapy practitioners are continually seeking effective strategies to promote skill acquisition and independence with children with autism spectrum disorder. While video modeling has been widely embraced in fields such as speech language pathology and applied behavior analysis, its use in occupational therapy has not been as apparent. As children with ASD tend to have difficulties with abstract thinking, social cues, communication, and attention, video modeling and the VIS capitalize on concrete thinking and visual spatial skills that are typically a strong skill set for this population. Individuals with autism spectrum disorder have also shown an affinity for technology, process visual stimuli over auditory at a faster rate, and may perceive videos as a recreational activity that increases motivation to engage in intervention. Research investigating the efficacy and benefits of video modeling when working with individuals with ASD have demonstrated it is also effective for acquisition and generalization of multiple skills to promote independence across contexts. As no occupational therapy practitioners are utilizing the VIS at Autism Care Partners, the purpose of the study was to examine their perceptions of the use of the VIS, identify barriers and supports to implementation, and inform future training and integration strategies for OT practice. Now we can dive a bit deeper into understanding the visual immersion system. It was developed and trademarked by Dr. Shane Howard from Boston Children's Hospital. It is a technology-supported and evidence-based approach that uses tools like video modeling to enhance communication, independence, and occupational performance for individuals with ASD and other developmental disabilities. To differentiate between the VIS and video modeling, it is important to understand that video modeling is one of many immersive and visual tools of the VIS. The VIS builds off of the evidence-based practice of video modeling that is used to teach activities of daily living skills, instrumental activities of daily living skills, or social interaction skills, and expands upon it to address teaching imitation, communicating directions, and communicating transitions. Why is this relevant to occupational therapy practitioners? The VIS is a concrete and evidence-based practice method that supports skill acquisition in individuals with ASD. It also provides step-by-step demonstrations of ADLs and IADLs to promote imitation and learning of a task. Additionally, it bridges the gap between observation and performance by making abstract tasks more accessible to clients. For this study, participants included licensed and registered occupational therapy practitioners at any of the Autism Care Partners network sites. The recruitment was conducted over a 6-week period through convenient sampling. A single mixed methods online survey was developed and adapted from the Video Modeling Perception Scale, originally developed by Cardone et al. 2015 to assess caregivers' perceptions of video modeling. The survey consisted of 57 Likert scale and multi-select questions and one open-ended question. Unbeknownst to us within this big network, only 5 OTs are currently employed and responded to the survey. With that being said, and that being very useful, my study shifted its focus to more of a development of best practice to train OT practitioners on how to use the VIS in general and specifically at Autism Care Partners, as the responses to the survey highlighted lack of familiarity with the VIS as a whole and lack of training and equipment as the main barriers, which helped inform the training I developed. This is an example of one of the VIS supports developed throughout our weekly attendance at Autism Care Partners. Pick up the laces. Cross the laces. Pinch the X. Put the lace over and through. Pull the laces. Make a loop. Make another loop. Cross the loops. Put one loop over and through. Pull the loops. Through weekly attendance to Autism Care Partners in Danvers and learning from our site mentor on how to design and create VIS-aligned supports while providing a unique OT lens, we learned the best practices for filming and photographing VIS supports. In terms of the environment, we simplified backgrounds to reduce visual distractions and used solid-colored settings. We eliminated clutter like furniture and decorations or objects not critical for the video content, and limited potential accessories on models that could cause distractions such as jewelry, nail polish, watches, hair elastics. We used strong contrast between key items, for example, a black talker strap on a white shirt. Lighting was also optimized to avoid shadows that could obscure task components. For example, if you had a video with a dark shadow under a tan hand against a brown door, it is going to be hard to see without proper lighting. In this case, you should prepare the video near a light or by a window. Lastly, we limited auditory distractions in the video, such as voices, ringing phones, background noise, and hallway noise. In terms of language, we used short, grammatically correct phrases such as sit in the chair, not sit chair. We spoke slowly and avoided unnecessary verbiage. We also employed semantic consistency across scripts to reinforce learning and support therapist-client interactions, such as push down the soap versus push the soap down. Lastly, for perspectives and pacing, we slowed down actions and inserted brief pauses between steps to allow for processing. We provided close-up and point-of-view angles to highlight fine motor tasks, and in some cases, we offered multiple perspectives to scaffold learning. Table 1 highlights the multiple perspectives of one task, zipping a jacket, created to support scaffolded learning. The ADL task of zipping a jacket can be graded down as zipping on a table and be graded up to zipping while wearing the jacket, a more difficult yet functional approach. The multiple perspectives help the learner understand the tasks in various contexts and generalized skills. As we developed and designed an array of VIS visual supports, we encountered several challenges and developed solutions. First, it was challenging to keep the language consistent across all visual supports we created, especially when trying to use the same types of phrases for similar tasks. To help with this, we developed a shared document where we recorded scripts for each video. This helped us make sure the wording stayed consistent and developmentally appropriate, making it easier for clients to understand and generalize the information across different activities. For example, if we used turn on the water, we elected to use turn off the water as opposed to turn the water off. Another challenge we encountered was task sequencing. It was a priority to ensure that the most appropriate motor planning sequence was considered in relation to the target population's age and ability for each task. For instance, we selected the bunny loop method for shoe tying as a developmentally appropriate approach versus the one loop method that we personally use on a daily basis. Lastly, contextual variation was a notable challenge. We wanted to ensure the task and its context were considered across multiple environments and offered grading and adaptations for different learners. For some tasks, we created multiple visuals in order to address this. In continuation, here are examples of contextual variation. Pinch the fabric. Pinch the button. Push the button through the hole. Pinch the button. Pinch the fabric. Pull the button through the hole.
Pinch the fabric. Pinch the button. Push the button through the hole. Pinch the button. Pinch the fabric. Pull the button through the hole.
Pinch the fabric. Pinch the button. Push the button through the hole. Pinch the button. Pinch the fabric. As demonstrated, for learning to button a shirt, we developed 3 types of visual supports. One demonstrating a button board that depicted the perspective of the individual buttoning, one featuring a shirt from the same perspective, and one presenting a front-facing view, simulating a mirror reflection. This approach was intended to promote generalization of the skill across different contexts and phases of learning. From our own experience, we developed implementation tips for occupational therapy practitioners. First, align the VIS video supports with client goals in the OTPF4. Select ADLs and IADLs that are meaningful and developmentally appropriate for your client population. At Autism Care Partners, practitioner feedback helped identify priority skills such as toileting, hand washing, toothbrushing, dressing, and snack preparation, tasks that align directly with the OTPF4 categories. Next, collaborate interdisciplinarily. Partnering with speech-language pathologists creates opportunities to incorporate developmentally appropriate language concepts within videos. Collaboration with VIS-trained SLPs also supports consistent use of VIS principles, reinforcing both language and motor learning in intervention. Next, for script and document, make sure to develop and maintain written scripts for each video modeling to ensure consistency in language and sequencing. This also serves as a resource for future video creation and allows all team members to reinforce the same language in sessions. In terms of addressing challenges with clinical reasoning, OT practitioners should anticipate and problem-solve challenges in sequencing tasks, selecting appropriate materials, and matching task difficulty to client ability. Clinical reasoning is essential in choosing age-appropriate methods, as previously mentioned, the bunny loop versus the one-loop shoe tying method, and adapting tasks based on client needs. Next, use a graded approach. The VIS supports can be tiered to meet each learner's developmental level. Offering multiple videos for the same task at varying levels of difficulty or perspective supports motor skill acquisition and promotes independence across environments. Lastly, embed VIS in daily practice. Integrate supports into therapy sessions, home programs, and caregiver trainings. By implementing these best practices, OT practitioners can effectively integrate the VIS into therapy sessions. These strategies not only enhance the effectiveness of intervention, but also promote standardization across providers, support interdisciplinary collaboration, and foster greater client independence through visual learning. In conclusion, despite evidence supporting the VIS, occupational therapy practitioners, specifically at Autism Care Partners, show low adoption due to limited training, unfamiliarity, and perceived barriers about equipment and scripting. With targeted support, interdisciplinary collaboration, and access to practical resources, OT practitioners can successfully adopt VIS video modeling as a routine intervention tool. OT practitioners can play a pivotal role in bridging the research to practice gap and expanding access to innovative interventions that empower children with ASD to thrive in their daily lives. References are available upon request or on the Padlet connected to this QR code. Thank you.